So today I want to talk to you about new exciting results of the STAMPEDE trial. The STAMPEDE trial is a very innovative trial design. It's a multi-arm, multi-stage design. And it has shown already a lot of interesting results that were practice-changing. It's for patients with prostate cancer who are starting ADT. So in general, these are patients with metastatic disease or high-risk localized disease or other high-risk non-metastatic disease. In this special abstracts, there were only men included with metastatic disease. The question was if radiotherapy to the primary, to the prostate, could improve overall survival. The results were rather exciting. There was no overall survival benefit for all patients. But if you looked in the patients with the low volume disease, there was a statistically significant overall survival. In the high risk patients, there was no overall survival benefit. That leads to the conclusion that we have a new treatment standard for men with metastatic castration-sensitive disease with low burden of disease. So the radiotherapy to the primary should be considered standard option, a new standard option for these patients. In total, I think this is a really new finding in prostate cancer, that if you treat the primary in the metastatic setting, at least in the subgroup with a low volume disease, you get an overall survival benefit. So the big question now is, obviously, if perhaps the combination of abiraterone plus radiotherapy to the prostate is going to be even more beneficial. We don't know that yet from the data we have, but there is Piece 1 coming, a trial testing exactly this question. And obviously we're looking forward to seeing these results. There's a lot to come, and that's very nice to see.
We're going to get an in-depth chat now about the STAMPEDE trial on prostate cancer, and here with me to tell us a little bit more is Professor Karim Fizazi and also Dr. Fernanda Herrera. Welcome to both of you.
Thank you. Thank you.
So how important is the STAMPEDE trial, do you think, in recent years on prostate cancer, and what kind of results is it now yielding?
STAMPEDE is a very important trial in the prostate cancer field. What we already knew before ESMO was that using abiraterone for patients with metastatic disease who have not received anything else until now is associated with improved overall survival, so duration of life, if ever you are a patient with what we call high-risk disease, so multiple metastases. But we didn't know whether this also applied to patients with oligometastatic disease, and this is exactly what the STAMPEDE group demonstrated yesterday at ESMO.
Fantastic.
Yes, because it's really brand new thing and it's changing the field. It's practice changing, very obviously.
And so what do we know about radiotherapy, when it should be used, how much should be used, which patients it should be used for?
Yes, what is the same? Because before this trial, there was a dogma where metastatic patients would be treated palliative, and the treatment, the local treatments, either surgery or radiation to the primary tumor, was considered to be useless. So this trial is practice changing because it randomized metastatic patients to receive either a standard of care, which was ADT, 18% of the patients received docetaxel also, versus adding radiotherapy to the primary tumor. And there were 2 doses of radiotherapy that were implemented, and they showed for the first time that actually when they look at the whole patient population, there was no overall survival advantage, but when they separated the patients in those that have low metastatic burden, defined as less than 4 metastases, versus those that have very high metastatic burden, they actually observed a benefit in overall survival with a very important hazard ratio of 0.6. So this is a practice-changing trial for the radiation oncology field.
And how will it change the standards of care of what is done in hospitals?
Well, I guess taken together, for this subgroup of patients with oligometastatic disease, the standard of care will change. Number one, abiraterone will likely become the standard of care on top of androgen deprivation therapy. And number two, we will have to consider irradiating the primary cancer. So it's two changes at the same time for the same group of patients.
And you're working on the Peace 1 trial, which is kind of in a similar area to this. How do these results affect your trial or dovetail with your trial?
Right, actually the two trials complete very nicely each other, and we're very good friends with STAMPEDE investigators, so we really discuss to try to avoid competition and to be complementary, if you will. So what Peace 1 is doing is that it's randomizing the role of abiraterone and radiation therapy, so the two same questions, but on top of a different standard of care, which is androgen deprivation therapy plus chemotherapy. So we're just about to finish the accrual in Peace 1, probably in a month or two. Almost 1,200 men will be randomized overall, and we will have new answers, if you will, regarding whether abiraterone should be used and also whether radiation therapy should also be used if you're treating your patient with ADT plus chemotherapy.
And where does this suggest that immunotherapy should be used in prostate cancer? Not very much, and it doesn't seem to work at the moment.
At the moment, it doesn't seem to work. Much preclinical efforts have gone there, but I think something that yesterday was pointed out during the session was that certainly this practice-changing trial with radiotherapy, you may assume now that irradiating more, for example, the lymph nodes, would have implications also in survival or in failure-free survival, which is not at the moment really proven, but it certainly implies that probably if we irradiate more, if we irradiate more oligometastatic patients, then we could eventually prolong survival. And then it raises the question also, should we irradiate the lymph nodes? Because antigen priming occurs in the lymph nodes, and how this would affect incorporating immunotherapy if one day works in prostate cancer. We don't have the answer for that yet.
And looking at biomarkers, which I can just ask you about finally, which ones particularly are looking interesting as predictive tests?
So we actually have many potential biomarkers in prostate cancer. None is clearly ready for prime time. Also, DNA repair gene markers, or HRD status, is appearing as something really, really important. And that's because about 10% of men have germline mutations, and perhaps an additional 10% have somatic mutations in these genes that can have two big consequences. One is for the patient himself, because PARP inhibitors or platinum treatments might be much more effective in these men, and this is something we're currently testing prospectively, but also for their families. If ever you have a 10% risk that you are yourself a BRCA mutant patient, it means that your family may also have it. And just by testing these men, you might save a woman's life from ovarian cancer. So it's really important, and more we're testing all our patients systematically when they have de novo metastatic disease, because we know that the incidence is higher in these men.
Perfect. Thank you, both of you, for talking to us today.
Thank you very much.